Okay, our next topic is risk management. A little scary on a Halloween, but Brad Duncan with NorCal Mutual Insurance Company is with us today and is going to focus on two areas. First is pain management and opioid prescribing, and then minimizing risk in the physician office setting. If we could, let me see a show of hands of how many of your states are requiring opioid training, and especially the opioid training. Yeah, I have a Florida and an Alabama license, and I get hit twice with it. Somebody asked me earlier if this will qualify for any of the state requirements, and I don't know that answer, but we'll find out and try to get you that answer a little bit later. Brad is with NorCal Mutual Insurance Company. Spent his career working in the professional liability field, providing consultation services to hospitals, physicians, and clinics on a multitude of risk management topics. And Brad, without further ado, I'm going to get you started.
Okay, thank you very much.
Thank you.
Can everybody hear me with the mic registering? Okay, great. Thank you. Thank you. Good morning, everybody. It's a real pleasure to be here this morning speaking about this topic. I've had a couple of opportunities to do that with physician groups and with insureds because it is an area that really is, as was stated, kind of scary, I think, for all of us in terms of what we see in the way of increasing professional liability issues related to opioid prescribing, from that standpoint. So basically the program today will start out in talking about just basically, what the problem is, what we're doing to, or what we can do basically to address this from a risk management standpoint. Many of you are already doing these things on a current basis right now, but it's also helpful to, and I think a lot of the information that I go over today will be very common sense from that standpoint. There are a bunch of slides to get through and some case studies. We use some closed claim studies that are actual case studies that are abridged just to kind of illustrate some of the points or things that can happen from a poor outcome standard or standpoint where there were professional liability claims involved. And that's really, as a risk management person coming from a professional liability company, that's what I'm asking you all to take a look at it kind of from that perspective, in addition to all the other things that you deal with your patients on a regular basis. Just by starting out, how many folks actually are actively engaged in chronic pain management with patients? So we do have some folks that are. How about folks, are any folks thinking about it from that standpoint? Okay. And, I think that it's really, as we're talking about it, I think it's an area that we really have to be careful about in terms of getting into, because you do really have to make that decision as to whether or not you want to do it. And if you do it, you want to make sure that it is something that's done completely and thoroughly from the standpoint of protecting patient safety, but also protecting yourself and shielding yourself from potential liability claims. Let me see how this is a little bit different. This is some background information. I'm a disclaimer here. I'm not an attorney. Some of the things I talk about have legal principles sometimes, but I'm not interpreting law or I'm not giving legal advice from that standpoint. It's just risk management advice. Basically, the learning objectives for today, just as far as housekeeping items here, we want to make sure that we're adhering to federal and state law pertaining to prescribing of controlled substances. We want to recognize the signs of potential drug addiction and diversion. And this is something that, I and my colleagues, when we go out doing consultation, I do ask providers, what kind of prescription medications they're involved in prescribing and opioids and what have you, because this is something that, it's another area that we're trying to help or make sure that folks are not causing problems for themselves inadvertently from that standpoint. And this is an area where you probably have, and I would probably venture to say that How many of you have difficult patients that you deal with? Is there? Oh, okay. Okay. Well, this is okay. So you have difficult patients. Yeah, that's a lot of time. I spent a lot of time talking to you about those kinds of situations. And you know, there's always a. I think I've heard everything, but there's always a call that comes in that, you know, I think, okay, well, this is a new twist on the story, and I really think, you know, you all are really in a difficult position in trying to figure out how to handle some of these patient situations. You know, the psychology that's involved in it, and the practice of medicine, and we're going to talk about some of those things to look out for. And I know you're very aware of the red flags that you look for when you're dealing with patients who may possibly be drug-seeking patients from that standpoint. Okay, and again, just to keep perspective on this, obviously there are patients who legitimately require, you know, ongoing chronic pain management from that standpoint, and do qualify for that from that standpoint too. So it's nothing to, but we kind of hear the downside of things, or at least from a risk management standpoint, I hear kind of the downside of things from that standpoint. And basically, you know, just applying best risk management principles. These are things that, the things that we're talking about today, you know, I think we live in a world where we say, well, you know, there are a lot of things beyond our control. You know, we had lectures on Ebola yesterday, and even there, you know, we're talking about, you know, yes, there are some things that are beyond our control, but there are things that we can do to manage our risk and also protect ourselves, protect our patients. So these are the things that I'm talking about, hopefully are things that can be applied in your practice and are pragmatic from that standpoint and not too difficult to do. And, you know, also as a provider, you know, and I was talking to some folks last night, basically, you know, setting limits with patients too and not being afraid to do that. Have any of you ever been in a situation where you've been kind of bullied or intimidated by your patients? Okay, I see some acknowledgement there. So yeah, that's part of this process too, and I think that I support your standing your ground, you know, in situations where patients are trying to get what they want, where it's not medically indicated, and, you know, they're challenging your knowledge and expertise and experience and years of experience and training, you know, from that standpoint. You know, basically with opioids, we're dealing with, you know, obviously powerful drugs, you know, for pain management, which do have a potential for addiction and also diversion too. Sometimes we get calls as well with not only about situations where patients are diverting drugs, but also maybe even office staff in some cases. So that's something that you know, I've had occasion to deal, and it's a very difficult situation, you know, from that standpoint. But those are things that have to be dealt with in many different ways, and it's not something that can be ignored. It may require some reporting to the authorities from that standpoint. Obviously, I don't want to say that, you know, you are all in the position of being the police. There are other agencies that take responsibility for enforcing things, and that you do have them as a backup to report issues to and have them deal with it or research into it and take care of any kind of suspects that are involved in these kinds of situations. But it's a pretty powerful subject from that standpoint. The history on this is just a little bit of background history. In terms of, you know, we're going back to probably a relatively recent time period, you know, a little over 20 years. Basically at that point, if you look at the use of opioids, it was pretty minimal from that standpoint. In fact, there was actually a case in the 1990s. There was a cancer patient who the patient I think had died, but the family or the estate did sue the physicians involved because they reported that the patient wasn't treated appropriately, wasn't given, you know, appropriate pain medication, and went through a lot of pain and suffering. So this got the attention of a lot of folks about this whole area of, you know, pain management and what have you. In 2001, we're looking at pain becoming the fifth vital sign from that standpoint. And then if we're looking at over, you know, 1999 to 2010, and I'm sure maybe it's even gone up since then in 4 years, the quadrupling of opioid analgesic sales. So that's not really a surprise. I think we're kind of aware of that, but we actually do have some figures and things to back that up. So the current environment that we're dealing with now, as opposed to 20, 25 years ago, addictions and diversion, overdoses and deaths, American consumption. I think, what are we? I remember reading the figure, we're 6% of the world population, and we consume 80% of the opioids that are produced in the world from that standpoint. So something's a little askew there from that standpoint. And then there's also the aspect of law enforcement, because we're aware of situations where, in some cases, providers are being arrested and being investigated for inappropriate prescribing. And there have been situations where patients have, overdosed, have died, and then there are criminal charges that are applied. And that's kind of, outside the area that I deal with respect to professional liability, but it is something to be aware of that could be a potential issue. And I think that, what was it, now I'm trying to remember because this year's gone by so fast. It was Philip Seymour Hoffman, the actor, that got a lot of attention when he died of a drug overdose. And a lot of people then started paying attention to that issue and raising the issue. And of course, I was interested from a risk management standpoint because we talk about these things. And here it is in the media from that standpoint that you have and unfortunately, sometimes it does take a celebrity figure to get the attention of the country, and it did. But, when I think about it, there was a lot of fanfare about that. And of course, I think all the fanfare has kind of died down a little bit. We don't really hear much about that anymore because we've turned our attention to Ebola and terrorism and other things at this point right now. But it's still out there from that standpoint. If you look at, and this again just gives you some trends with respect to going from 91 to 2010 in that study, you have the number of opioid prescriptions, hydrocodone and oxycodone, and basically you see there's basically a quadrupling there from 1991 to 2010. So here it is graphically shown, what the issues or the problems are from that standpoint. When we look at deaths from opioid pain relievers, look what we've got here. And these different age ranges and age range groups used to be, at least my understanding was, that overdose deaths were typically from illegal or illicit street drugs, things like that. Now it's the opioid pain prescription medication issues are outstripping illegal drugs by a significant amount when we look at this. So if you look at the kind of the tan bar as opposed to the blue bar, there's that again shows that there's definitely a big problem here.
Do you know if that means the tan bar only includes prescribed and not street obtained?
I'm sorry?
Do you know if the tan bar only includes those prescribed for those patients and not illegally obtained opioid pain relievers?
Well, that's a good question, and I'm not sure about that, but that could possibly be wrapped in there. I was thinking that mainly it's calculated on those prescriptions that are prescribed, that are tracked from that standpoint, and so that's a good question, and again it figures into the mix from that standpoint. Regardless, it is definitely an issue and a problem, and these are the kinds of things that kind of got my attention because I realized over the years I've been talking with providers and we've been dealing with this issue, and you have a sense that there are problems, but when you actually see it, in this kind of situation graphically, and then you hear about how, as a nation we're consuming so many opioids, I think that part of it is in this culture, painkillers are easy to obtain. Even for me, I had a tooth removed a year ago, and everybody was pushing, you're going to have pain, take this, and I have a high tolerance for pain. I didn't need anything. I'll just take Tylenol or something like that. But no, here's a prescription in case you need it. Everybody's so willing to hand out something, So there's that kind of thing that goes on, and I started thinking about how that's an issue, and not only that, but I thought also nobody ever asked me, they didn't. Well, in my history, does Brad have any issues with prescription medications or a history or anything like that? They just said there was no question to me about that. So I think that's one of the things we talk about as well, too, in terms of screening patients and finding out as much information as you can and background information. This was something that came out recently in 2013, which got a lot of folks' attention, where they were looking specifically at women with respect to or related to the number of deaths due to overdoses, and there was a 400% increase since 1999, and they were, 5 overdose deaths were 5 times higher since 1999, and that was just focused. That was a CDC study done on women. One of the issues that was related to this, some of the findings that came out of it, was that in some cases it was found that some women were more apt to do, doctor shopping, had more issues with, pain issues and things like that, were drug seeking from that standpoint. So again, that's something where they divided it out. Again, just illustrating the problem that we've got. And then, of course, prescription painkillers may be a slippery slope towards a relapse to former heroin addicts. And I think, that was something that was related, again, to the Philip Seymour Hoffman situation, where it got a lot of attention. And it's something that, again, you read about these things on a regular basis, and hopefully you're thinking about, how does this impact me? What am I doing to, obviously provide good patient care, but what am I doing to protect myself from a professional liability standpoint? In some cases, there has been the use of Narcan, which is, and I don't know, you may be more familiar with this across the board because so many states are represented here today. Is there any legislation that's being considered in your states about the counteractive use of Narcan? So I see some head shaking from that standpoint. Yes?
Yes, there are bills in front of Louisiana legislature regarding third-party and EMS use of the Narcan injection.
Right, and that was something that was kind of controversial, from that standpoint. But again, they figured that this was an opportunity to save lives from that standpoint. I know, being from California, I know there was a bill in consideration. I don't know if that's been finalized or not. Obviously it's important for first responders, even providing, I think in some cases it was considered maybe even providing private citizens from that standpoint. And you get into all sorts of interesting issues along those lines.
We're talking about that in Kentucky right now too, because we've got a huge problem with heroin in the area and prescription pain medications as well. But that's one of the things where, you've got an 80% chance of relapse if you're addicted to heroin. So is it best to put some Narcan in the house?
Well, and then are you just, then does that create kind of a false sense of security that, well, I've got a backup plan, and
Then we'll give it to a parent or family member and say, hey, don't tell them you have it.
Right, right. Well, yeah, there's all that kind of thing that, how do you regulate that? How do you train people on the use of it, from that standpoint? Are there maybe even ethical issues involved in that? I don't know, from that standpoint. I mean, obviously, it maybe takes some of the focus off of addiction treatment, which is obviously important. But again, this is something as a solution, may not be the best, but it's something that can help save lives. So if that's the justification, then I think it would be valid from that standpoint. I think that we'll see more and more of those kinds of things too. I'm not a clinician. I'm not an expert on pain management. Basically, we talk about kind of the basic definition of pain, unpleasant sensory and emotional experience. The emotional part of that is in there too, which is primarily associated with tissue damage or described in terms of such damage or both. And that's just kind of a general statement about, pain. Obviously, there's the sensory part of it, the location, the duration, the intensity, from that standpoint, the motivation or kind of the emotional part of it, how it affects people, how it affects behavior and outlook, anxiety, depression, those kinds of things. Then there's the cognitive aspect or the evaluative part. And this is the part that's, I guess, difficult because, when you are asking patients to, how do you assess pain on the part of patients? You ask them on a scale of 1 to 10. Do you use any graphics or anything like that to kind of have them indicate. And of course, everybody's response to pain may be different from that standpoint too. Again, it's hard to gauge that where you're trying to objectively measure something that may be subjective from that standpoint, which is, again, difficult. And it also relies on, the honesty of the patient as well, from that standpoint too. I think that, and again, bringing perspective to this, I don't want to make everybody think that, I have to be suspicious of everybody. But I think the patients where, you want to take a little extra time and talk with them, try to figure out what the motivation is behind what they're asking for or what they're doing, or your relationship with that patient. Because I would say in this case, too, that especially when you're involved in this kind of thing, trust is really an important aspect, if there ever was, in the doctor-patient relationship from that standpoint. And you have to rely on patients being truthful with you. There are ways that you may also reinforce that or ask for accountability along those lines as well, too. So we'll talk a little bit about that as well. Acute pain, some of the characteristics, temporal onset. There are objective physical signs, but then the downside are the risks that it can develop into chronic pain, and then there's a potential possibly for over-medication, which is an issue. Chronic non-terminal pain, there's no temporal onset, it's intractable. There may be misuse or overuse of prescription meds or opioids, and poor monitoring. And this is something where, you may want to consider alternatives to just throwing drugs at the situation. There may be other issues that are going on that need to be addressed, maybe psychological issues, consultation with psychiatrists or psychologists. A lot of times when I'm looking at going out and looking at medical records and practices when I do some consultation, and I look at what's going on, and I'm trying to figure out, as a layperson, the story of what's happening with this patient. And I'll see that on repeated visits, a patient comes in and they're characterized as being depressed or anxious, we're prescribing medications, but then there's no other aspect there to say, have we considered maybe, getting some kind of referral for this patient to a psychologist or a psychiatrist because their behavior is not changing, they still exhibit the same symptoms, and they're not getting any better from that standpoint. But we just, dutifully record the fact that, these are things that are going on, so we've got that in the documentation. But then I would hate for a plaintiff attorney looking at a case, if there was a suit, to question that and say, you've seen this patient for all this time, and did you ever consider, any other alternatives? Because, it doesn't seem that what you were doing here might have been effective or efficacious with this patient. So the risk, basically, again, we're talking about liability. Regulatory is kind of a little bit beyond the scope here because we're dealing with so many different states here. I will talk a little bit about that because obviously there are federal regulations and state regulations regarding opioid prescribing. Many of you are aware of one of the most recent changes that got everybody's attention was the change by the FDA regarding hydrocodone. And now, when I went to the pharmacy the other day, I was greeted with a sign that was telling me, not that I was looking for those medications, but it just basically said, there are new rules, and that's the education that's going out to the patients, from that standpoint, that they're aware. And I'm sure that some people are seeing that, and maybe some patients are not too happy about that. But I think that, again, those are good risk management principles. Those hopefully are going to help you, with having those regulations in place, because you can defer to the law and say, I can't do this because I'm obligated by law to follow these regulations, and so therefore gives you a little bit more of leverage from that standpoint in dealing with that. And then also the possibility of prosecution, and that's something that definitely you don't want to be put in the position of. And I think part of that, and I was hearing an attorney who specializes in, defending doctors who are brought up on charges of opioid prescribing issues. And basically, he said, that the DEA or the police are coming at it from a different perspective, because they're not thinking about necessarily patient care. They're thinking about, drug trafficking, illegal drugs, the misuse of drugs or diversion of drugs. You're thinking about patient care. Your perspective and philosophy is different in terms, so there's kind of a collision there of those two different kinds of philosophies. And, law enforcement and what have you have to understand that, by and large, you guys aren't criminals from that standpoint, but you may feel like you're being treated as one if you're being interviewed by an authority figure along those lines. So, and it's not pleasant, from that standpoint. The professional liability is, the fact that there are multiple medications out there. You have to have knowledge of those medications. It's important from the standpoint of monitoring patients. Typically, in some of the cases that we see, there's failure to monitor patients on a regular basis. And just, the fact that, medications are prescribed and continually, but then there's no maybe recheck on the patient, or they don't come back to the office, or it's hard to get them back in, but you go ahead and fulfill their prescription. That kind of thing can happen. Consults, maybe getting additional information, again, as I talked about, from a specialist or a pain management consultant, or a psychologist or psychiatrist, in dealing with some of these issues with patients. And then obviously referral for when, in many practices I go to, they say, we don't handle, pain management patients. We'll refer them out to a pain management specialist. And that kind of eliminates a whole area of liability for them from that standpoint. But, we have, and there are patients, I think, that you deal with that you have a suspicion or even proof that they are doctor shopping, that you are maybe one of many physicians that they've come to see to try to obtain medications along those lines. And hopefully there are ways for you to ascertain that. And and we'll talk about it, well, we can talk about it now, in terms of prescription drug monitoring programs. Is everybody aware of it within your state if you have one, or do you utilize it? So, for the most part, do you find it effective, from that standpoint? Yes and no? Yes?
The state of Florida, because we were Pill Mill Inc., and among other things, the pharmacies got together and they pretty much computerized everything about drugs that people are taking in any level of pharmacy. And they were able to cross-reference who's getting drugs. And I got calls when I was writing for small quantities that this person has another provider, and I'd just send them a letter and see them the next time and say, nope, in this state, we want only one person to prescribe your medicines, so we don't get in trouble and you don't get in trouble. That's the law. Mm-hmm. And that really helped back up the physician's authority. And It's a great idea. It can be done in any state. Right. And it's amazing how many of the people on any drug have a computer record of that drug.
Right.
It was very helpful.
Right. I know that's something that some programs are better thought out, better set up technology-wise and access-wise, user-friendly, available from that standpoint. Some are underfunded and not. I live in California, but I travel all over the country now, but there's something, we have a ballot initiative coming up on the November 4th election next week. It's regarding a thing called Proposition 46. And what it is that, and this is something that California has had MICRA in place for many years, since the 70s, and that's a cap on non-economic damages of $250,000 for claims. Not economic damages, but non-economic damages. There was a situation where I think it was a gentleman's family was killed in a car accident where a patient was operating the other car, hit the family, and the patient was on prescription meds, was driving under the influence. And so This got everyone's attention, and then I think the husband and got together with other folks and advocated for the fact that there should be better regulation of this. And so, coupled in with trying to raise the $250,000 cap, they also want to add in a requirement that any physician in California who prescribes prescription, opioids, prescription medications, consults the Cures, with what we have, the Cures database. And then also, physicians themselves will be subject to random drug screening, from that standpoint as well. And all these things are kind of packed into that initiative. And this is what the population of California is going to be voting on. And they may not necessarily understand all the issues. Obviously, I follow it from the standpoint. And there are many organizations that are against it because they don't think that that's the way to get at the issue, and that they feel that this is an opportunity for trial lawyers to just get in there and make more money for themselves, in claims and things like that. So it's kind of complicated, but it finally, and this is something I guess we've been concerned about for years, and it's something, I mentioned that even though it's happening in California, could it possibly happen in other locations as well, when the rest of the country gets wind of this kind of thing happening. And I know that in many states where I go around, there are either medical malpractice caps on damages or non-economic damages from that standpoint. And there's always an attempt to adjust them for, inflation and cost of living, and that's the justification, because they say, well, this thing's been in place since the 70s, but really, I think trial attorneys see that as an opportunity to make more revenue, in cases and things like that. So that's something to be watching for, and I'll certainly be watching for it as well in the election. In a case study here, basically, this is just an example of a situation where, and again, these cases are so abridged because, when we're looking at closed claims or actually open claims when we're investigating something, and our, claims in any professional liability company is looking at a claim, obviously the investigator is going to look at it, medical experts are going to look at it, physicians are going to, the physicians or medical experts looking at these cases, trying to determine, what kinds of things have happened. This was a case of a 43-year-old female who presented to the primary care physician with a chief complaint of severe lower back pain. And the history of this patient, it was that she was seeing a psychiatrist. She was on various medications there. The primary care physician referred her to the orthopedic surgeon, and the diagnosis there was degenerative disc disease. So here we have kind of a lineup or a chronology as to what was going on February 20th. Orthopedic surgeon prescribes 25 milligrams of oxycodone. Then coming up on October 4th, the ortho refuses to refill the prescription, and then the patient goes back to the primary care physician, and the primary care physician picks up and fills that prescription, and he adds hydrocodone and increases the diazepam. And then October 22nd, there's a refill on oxycodone. October 27th, oxycodone, there's something questionable about the time frames there too. November 6th, November 15th, the patient's found unresponsive and had died. And again, a real case, names are, and all identifying information is taken out of it from that standpoint. And this was just kind of to give you an idea of, again, the volume, I guess, of the medications that were prescribed over that time period, which would be, well, according to the experts, would be considered excessive, from that standpoint. In this case, there was a wrongful death lawsuit against the primary care physician. And this is what it comes down to. The allegations were that there were no consultations. Apparently there wasn't, communication between the primary care physician and the orthopedic surgeon. There was refill with no examination. That situation happened. Excessive narcotics. In this case, there was no screening for addiction, and maybe this patient had a history where that could have been, been more sensitive about this whole area, because there are obviously situations we acknowledge where patients who have not are actually become addicted to medication when it's prescribed to them. And poor documentation. That's something that we're going to talk a little bit about in the next session. Documentation is so important. I know you all are dealing with that in terms of your migration, hopefully successful migration from paper charting to electronic medical records. Documentation is still very important, from the standpoint of patient care. It's very important also from the standpoint of defending cases, and that's something that, professional liability, your professional liability carrier needs that information, needs good information to defend cases because of the time frame which these things play out over. And so you definitely want to make sure, and again, I'm not talking about quantity of documentation, we're talking about quality of documentation. And those are the things that, again, we'll talk a little bit more about that and how that's important as a strategy to minimize risk. And what comes back, unfortunately, and this is something that makes it hard to defend cases, is when you get negative expert reviews. And basically the bottom line is that the care in this patient was mismanaged, which led to a tragic outcome from that standpoint. Something that when you look back, and again, we're talking about things that are within our control and controllable risks, this is a situation that could have had a different outcome if some factors had been different. And a lot of times when you look at some of these situations, and I've read these cases where there are interviews and depositions of all the folks that are involved, and there's a whole story there. There's so much detail. And you start seeing where, wow, if at this juncture something different had happened, it kind of set off a whole bunch of other stuff that led to this problem, kind of like a domino effect, from that standpoint. Obviously, too, there's concerns about the state and medical board investigations and with respect to license proceedings and fines that are associated with infractions. There are DEA investigations, possible revocation of DEA numbers and fines. And these fines, as you know, are not, they're not covered by, your professional liability insurance. That's something, these are, civil fines, that kind of thing, or criminal fines, from that standpoint that can be problematic along those lines. So again, that's something to keep in mind. I think that what's important and what you should do is check with your liability carrier in the event that you ever are investigated by your medical board or by the DEA or a governmental agency, that you may have some form of what we call physician's administrative defense coverage, which would enable you to have access to legal counsel to help you respond to these types of situations rather than trying to do it on your own. And I get lots of calls sometimes when talking with a physician who, somebody made a report to the medical board and it's kind of unfounded or there's not a lot of merit to it, but obviously the medical board has to do their due diligence and investigate these situations. And then they come back to you asking for, the medical record and what's your side of the story. Many of these things I see, they come back and the medical board says, we've investigated this, we don't really have any finding against the physician, but they and you have to go through that whole process. And so it is sometimes cumbersome and time-consuming, but definitely I would recommend that you contact your liability carrier to see if there is assistance provided along those lines. In this particular, this was just a medical board case where there was a 48-year-old female patient presented to her primary care physician with chronic back pain and received a prescription of hydrocodone. And, she received this same prescription over the next 3 years. And then, she eventually filed a complaint with the medical board. And I think the backstory on this was that she went to another provider or a colleague of this provider who she'd been seeing who had been prescribing the medication for 3 years and really not adjusting it or anything like that. I mean, this was just an ongoing thing. And so it makes you wonder, what was the monitoring process? What was the justification on the part of the physician to be prescribing this without, saying, is it having some effect? Do we need to change something? Do we need to do something different, along those lines? So the patient, once talking to the new doctor, probably may have said something like, maybe raised out in her mind as to, well, why has this been going on for so long? And, I don't agree with what your previous doctor is doing. And you run into those situations where you have patients that come to you that are asking for a second opinion and, you know, you have to be careful about what you say about the other provider. Really, you want to focus on what you can do for the patient, regardless of what's happened with the patient prior to that. I've been in a situation where I got a second opinion. It worked out well. Actually, it was very beneficial. Nobody should take it personally, you know, from that standpoint. But here was a situation where the patient did file a complaint with the medical board, and the medical board looked into it, and, you know, obviously they're looking at the medical record documentation was poor as far as, you know, providing rationale for why this medication was being prescribed over the time period. There was, no informed consent to the patient about maybe the possible addictive effects of being on opioids or prescription medication. And so the outcome, you know, for the provider was probation and education from that standpoint. And fortunately, I mean, in this case, you know, we didn't have a poor outcome with a patient death or something along those lines. But again, this caused a lot of problems. It even gets to the point, you know, where we're looking at potential criminal charges, and you may have seen some of these things in the media occasionally, where a physician can be charged with murder, manslaughter, even drug trafficking, you know, from that standpoint. And again, as I said, you know, the authorities are looking at it from a, you know, prosecution standpoint. And, and not only that, but when you may be involved in some of these situations when it comes to drugs, I believe there are situations where your assets can be seized, and, you know, all sorts of things can be, you know, personally can be, there are repercussions, negative repercussions for you possibly from that standpoint. So is everybody scared at this point on Halloween? Yeah? Yeah. Again, you're aware of these things, you know, and again, it's to have perspective on being aware of it. And again, there are things that hopefully, you know, you are doing, or that you will think about maybe implementing or talking with your colleagues or your staff, your office staff, in terms of looking at these situations, or looking at patients that you may be concerned about, and maybe taking a closer look along those lines. This was just an example of a DEA case where, you know, the allegation was conspiracy to distribute pharmaceutical controlled substances. How about, you know, are you dealing with patients who are trying to go online and obtain medications? And there are possibilities, you know, in some cases where patients can do that. And obviously, you know, there's no, in that case, you know, there's no doctor-patient relationship, you know, and that was a situation that was found in this case where a doctor was providing, apparently, filling prescriptions online for patients, and, you know, it received 25 months in federal prison. So that's kind of a long time. I don't know, maybe not long enough. Who knows? It depends on the implications for the patients, you know, from that standpoint. Another DEA case involved murder 2, unlawful sale and possession of controlled substances. Again, prescribed without indication. Several young adults overdosed and one died, and there was a guilty verdict where the doctor would receive 10 years to life in prison. And I think that may be referring to a case that happened in California, where it was just, you know, really a messy situation, and again, it got a lot of folks' attention. And these are the extreme circumstances, but again, it just brings to light, you know, that there is this kind of thing going out there, and it's not helping us, you know, deal with, you know, curbing these situations. Another DEA case, dispensing a controlled substance outside the scope of professional practice. You know, that's something that just briefly, for those that, you know, are engaged in doing chronic pain management, you know, if there's ever a case where you may be involved in a claim, and you know, you may be even held to the standard of a, you know, pain management specialist from that standpoint. So that's something to keep in mind as well, in terms of following the standard of care and, you know, guidelines and protocols along those lines as well. So that's something to be concerned about too. This slide should have been changed, because I should have said just in general, because we're talking about, you know, all the states. There are, you know, there's federal regulations that determine, you know, how prescription medications are handled and by whom, and how that's, you know, regulated by the federal government. And, there are updates that are coming out as we see on, like the FDA and that kind of thing. I didn't mean to have state of Illinois in there. In fact, I thought I had Florida in there. But again, I'm finding most states do have, as you indicated, there are state-specific regulations for prescribing medications. And those, are probably under more scrutiny as time goes on, and we may be seeing more developments along those lines. And so we have to kind of stay tuned to that kind of thing. And sometimes we don't necessarily get the information. We may have to go looking for it, or hopefully, medical association or your state medical association or the medical board, those organizations can assist you with keeping up and current with state laws and codes regarding these things. We talked about this a little bit already with respect to prescription monitoring program. You could put Illinois, California, Florida, many states that have these programs. Again, how effective is it? The other thing about the California situation that I was mentioning is that in that ballot initiative, if it's voted by the electorate into law, that is going to put a tremendous strain on the current cures or prescription monitoring program that's in place. And the director of that program has said, even before all this, is that we're having a hard enough time keeping up with the demand as it is now. But if you're going to make it mandatory as opposed to a voluntary thing, then it's, we don't have a system that's going to be able to handle it. Probably going to collapse or be overwhelmed. So again, that's something they had even thought maybe a few years ago about actually because of funding and California's budget issues, they were going to just eliminate it. But fortunately, it was saved. But again, it wasn't given much support or funding. And so, how effective is it going to be? It's better than nothing, I suppose. And hopefully, in your states, you have more effective programs that you can consult with. And it may be a useful tool in detecting abuse. And just as somebody had mentioned, where you find that, a patient is seeing multiple physicians. And again, it's a little bit of additional information that you get that can help protect you, and then also confront the patient and say, this behavior is not acceptable. We need to do something different. There are certain ground rules that we have to adhere to. So then back to that question I guess I asked earlier, do you really want to get involved after all this with respect to, prescribing opioids? Because of the medications, the knowledge, having to have knowledge of the medications and possible interactions, pharmacology, doing proper assessments of patients, which includes, not only just getting a good history and physical on the patient, but then, do you actually try to obtain, prior records? Have you had any patients that came in and said, those records are gone, or they don't exist anymore, or my doctor went out of practice or doesn't practice anymore, so they're just saying that there is no way to get prior records? Does that make you a little suspicious maybe in those circumstances if you've run across that? So yeah, there's things like that can happen. Then obviously with respect to the monitoring part of it too, as we saw in some of the previous cases, there wasn't monitoring going on. It was just basically, renewing a prescription and, not really questioning it and not having the patient come in on a regular basis. And at some point sit down and say, this doesn't seem to be working. What do we need to be doing differently here? And managing expectations, because I suppose that the perception of the patient is that, more medications, more relief. They know in a lot of cases they specifically know what kind of medication they want. I think we talk about that a little bit under the red flags, and I know you have your set of red flags that kind of pique your interest or raise your suspicion about a patient that may be drug seeking, or that higher doses will equate with feeling better, along those lines. So obviously, from the standpoint of risk management recommendations, and that's what we're talking about today, having a good and thorough, proper examination of a patient that includes, as much background and history on that patient prior to them coming to you. I talk with physicians who, in some communities where some patients are pretty well known. they've kind of worn out their welcome because they, you know, and that's another thing too. You know, one of the things we'll talk about in the next segment is about, you know, termination of the doctor-patient relationship. And, you know, I always often wonder when a relationship can't be salvaged and there's a decision to terminate that relationship, well, maybe you're getting rid of your problem, but then whose problem is it going to become next, you know? And certainly that's not something in a community you want to push off to another colleague, you know, unbeknownst to them. I even had sometimes patients in their termination letter saying, I'm not providing care for you anymore, but the following doctors, you can contact them and, you know, you can take up care with them. And I said, well, you know, do they know that they're on your letter here, that you're referring them out? And no, in many cases they don't. So, you know, you just want to make it more general and make it the patient's choice, you know, refer them to their health plan, refer them to the medical society, to then get a list of doctors who can help them, and then they can make that choice so that you're not actively making that referral. You know, the pain assessment tool, you know, I think I have one in here as an example. Monitoring pain level, and then, you know, is there any change, you know, with this patient? If the pain's always the same, then, you know, what do you do in that circumstance? You know, I mean, then you have to try other alternatives and consider other things. The pain scale, that's pretty popular, you know, from that standpoint. Does anybody have anything different that they use from that standpoint?
I think that's fine if you're starting treatment, but really when you're already in treatment, I think it's much more appropriate to say, is your pain adequately or inadequately treated, and what sort of functional limitations do you have with it? Because otherwise, if you've got a note from a patient that says, I have 10 out of 10 pain every day, and you're writing long-term narcotics, if I were asked to review that, I would say, why were you still writing it if it's not changing anything? So. Right. I don't know, I think the pain scale can kind of get us in trouble sometimes, plus you get a lot of 15s, which can get annoying.
Right. Yeah, that's true. And again, this is trying to apply something like an objective measure to something that is subjective on the part of the patient. And you know, I mean, I know, you know, just speaking personally, I think I probably have a pretty high tolerance to pain. I don't enjoy it, but I mean... All men think that? Okay.
Well, my wife was, when she came in labor, they said, well, what would you rate the contractions on a 1 out of 10? And she said, 5 or 6. And they said, oh, you're not in labor. And I said, well, what's the worst you've ever had? And she said, about an 8. And I said, what was that? And she goes, well, when I delivered without an epidural or anything, that got up to about an 8 at one point.
Yeah.
So it's so personal.
It is. But, you know, I mean, and again, there are patients where, you know, they are legitimately in pain, they have issues, and you're trying to help them. But then, you know, you have the patients who come in and they have all the textbook symptoms, and they can recite to you, you know, because they know what they're going to get out of it, or they know they want that specific medication, the specific dosage. Don't give me that because it doesn't work. You know, the other one, you know, I want this one. You know, and these are all the little, you know, red flags. And this is what you guys tell me in terms of the things that you're encountering, you know, from that standpoint. You know, we talked about earlier referring to specialists where needed, where, you know, if you're at a juncture where you think that would be required, and it's probably a good idea because there's, you know, you're dealing with this patient is not working, and that. At that point, and then you'll sometimes probably have patients that say, no, I don't want to see anybody else, I want to just continue seeing you, and, you know, don't send me off to somebody else, you know, and you deal with that situation. You know, every situation has a, you know, a certain story to it, you know, from that standpoint. The documentation, again, is important in terms of documenting what is the effectiveness of the medication, you know, and what are other things that are being considered. And noting patient compliance, you know, from that standpoint. And I think we talked about, addiction education, that's also an important part of it in terms of, you know, when prescribing these powerful medications, you know, that there's got to be an informed consent process or an educational process that's part of that as well. I think that's very important in terms of the, you know, potential side effects or addictive properties, or just knowing what you know about the patient's past history, you know, that's included as education to the patient. Because as we saw in that previous case, the woman had claimed that she didn't realize that, she was kind of addicted to this medication and nobody had told her about that or nobody warned her about that. And so, when a person like that is, sitting in the witness stand and talking about that, I often say, they say, and in most cases, trials, they don't go to the trial level in a jury or a court, but, those are the ones that get attention. And when they say that you're tried by a jury of your peers, well, are those, 12 doctors sitting in the jury box? No, it's more likely 12 patients, or people that have had, and they're dealing with looking at it from the patient experience. So they're going to understand or sympathize with that patient, that, nobody told her or nobody explained this to her. And, there could have been unfortunately there wasn't a bad outcome or a tragic outcome to that. And of course the prescription drug monitoring programs, utilizing those, and hopefully again they're user friendly. Even communication, amongst providers where, you have situations where a patient's been referred to you or you need to refer someone out. Having that not only documentation but communication and documentation of that communication as well to make sure that everybody's on the same page with respect to some of these issues. This case study was a 49-year-old patient. It was back in November of 2009. This is the Dr. A and Dr. B case. I think Dr. A, the patient went to Dr. A with a chief complaint of back pain subsequent to a fall off of a ladder, I think. And the Dr. A prescribed codeine-3 and advised minimal use from that standpoint. Patient, November 2009 to May 2011, almost 2 years, was seen every few months and received refill of medications. In May of 2011, though, Dr. A saw the patient for the last time and refilled the medications. But there was another thing going on, too. Unbeknownst to Dr. A, the patient started seeing Dr. B in April of 2010, so there's an overlap there. Patient told Dr. B that he was unhappy with Dr. A and wanted to change physicians, although he was still seeing Dr. A. Dr. B prescribed Vicodin and morphine, and basically patients saw Dr. B for over a year while simultaneously seeing Dr. A. This is kind of that nightmare situation. So, you've got this kind of comparison in terms of chronology here, in terms of what was going on and what was prescribed. And basically in August of 2011, the patient's found unresponsive. The autopsy revealed multiple medications, including Vicodin, codeine, and morphine. And again, here's a case where there was a suit filed against both physicians in this case for a wrongful death. So, what happened there? Well, in this situation, here's a situation where maybe consulting that database would have been helpful in terms of determining, it's not always surefire, but it could have maybe helped in terms of unearthing this particular situation. The interesting thing about this, too, is that in this patient's case, there weren't a lot of signs of drug-seeking behavior. The patient wasn't like overly eager or anxious, didn't ask for early refills, was very compliant and kept appointments. But the thing is, in terms of the case evaluation, too, the patient in this case was dishonest. So there was culpability on the part of the patient. It wasn't all on the part of the physicians, from that case. Because he paid Dr. B cash for medications and or meds in cash, and then basically disclosure. There was no disclosure. So there's patient responsibility in this particular situation as well. Yeah.
Do you know whether the patient was using one or multiple pharmacies?
Well, that kind of figures into it too, as far as those. Sometimes you may even have pharmacies who have called you and said, "Hey, I noticed something strange going on here," or you may even get. Sometimes I've seen where there are it's like a third-party administrator for like a prescription medication program for a health plan. They pick up on kind of unusual patterns, and they send a letter to you saying, we've noticed, you have this patient and we've detected some unusual prescribing patterns, and they're asking you to comment. And then in that letter, you see all these other doctors that the patient's seeing and who they're obtaining drugs from, from some. And there may be ways that the patient can obtain medications without, getting on that radar. But that's, those are the kinds of things that do happen. And you may be contacted by a pharmacy, and then what do you do in that case if you're told by the pharmacy that you have a patient that's, gaming the system?
The key to that is they pay for their medicine from one of the doctors in cash.
Yeah.
So that means they were basically keeping
Off. Right. And yeah, I mean, again, the dishonesty of the patient, and again, the doctor-patient relationship has to be built on trust, and there are, again, these are the exceptions, but they're the bad exceptions from that standpoint, and it was definitely a poor outcome for the patient, too.
And this really, with the monitoring systems and in some cases large communicating EMRs, lots of things change. Because I'll have people come in and say, oh yeah, for years and years I've been on Klonopin 2 milligrams 4 times a day. Well, I'll pull up their prescribing stuff, because we have to in Kentucky, and I'll see that they haven't had it prescribed in 6 months. So it's that sort of thing where they say, oh, I just want to stay on what I'm on, I'm here to establish. When you have that available, it's a lot easier to say,
Right.
yeah, we're not, because they'll sell it to you. They'll say, hey, I don't want to withdraw.
Right. Yeah, well, there are all sorts of manipulations that are going on. I've even had doctors that some patients have tried to use essentially extortion or blackmail to get what they want. There's a call I got, I think, from a doctor who was seeing a man and woman who were dating one another, and one day the female patient went in, and then the next day the male patient came in and started saying things like, my girlfriend told me that you sexually assaulted, her, and, I won't say anything as long as, I can get, he made demands in terms of getting certain medications, that kind of thing. And, I mean, people will go to all sorts of lengths, from that standpoint. And, obviously the doctor called us, and, I said, stand your ground as far as that goes, and, you can, you have a good reputation in the community. People would not believe this, and don't, let patients, intimidate you or bully you into these kinds of things. But obviously, when that does happen, you may want to contact the authorities, you may want to contact your malpractice carrier for guidance in terms of how to handle these situations. Hopefully your professional liability carrier does have, risk management that you can contact them and ask them and troubleshoot these kinds of questions. And if, from the standpoint, I'm not an expert in everything. Hopefully, I may not know the answer to the question right at the moment, but I certainly will research and get into it and try to figure out, and hopefully I'll ask the right questions to try to figure out what's actually going on in the situation. In this case, too, documentation was problematic along those lines. I should stop. How are we doing on time? Am I? Okay, good. Drug-seeking behavior. Okay, well, the red flags. What are your red flags?
Early calls for refills is probably number one, or multiple providers prescribing.
I had a listing here somewhere.
Canceled appointments with the person who was writing them and then rescheduling somebody else in the practice. Shows up with it.
How about, there was one, I know one where there was the patient's non-compliant on other things other than getting their medications. That's one, I think, there. Yeah, I mean, that's, so there's kind of that issue. I had a bunch of them here somewhere. Oh, here it is. It was in my request for a drug by name, seeing multiple physicians, recites textbook symptoms, you're unable to obtain prior records, shows up for the appointment with pharmacy, test results, all the stuff they need to justify getting what they want. Failure to follow through on everything other than getting their pain medications. The pain level never changes, it remains the same, so there's nothing really changing there. Calls for early refills, lost or stolen medications, so we've had the one where the dog ate the medication too. Let's see. And then if you're, the other thing is if you're we get into, well, we can talk about that a little bit in terms of, these are some of the things where obviously the pain medication agreement, how many of you utilize a pain medication agreement? So I see folks that do that, and that there are, and that's a really good thing from that standpoint, because it gives you, particularly when you're talking about possibly terminating the relationship with the patient, we always run into this situation where, well, yeah, there's a problem, but do you run the risk of a patient abandonment claim? Then the patient turns it back on you and saying, well, you're abandoning me, because you're terminating your relationship with me. But if you have that pain management agreement in place, many times it will stay. And if folks want an example of that, there's contact information on the slides. You can get in touch with me. Basically, it gives you an out because, it's a contract or an agreement that has certain conditions that, you agree to and the patient agrees to, that this is what I do as your provider. This is what you do as the patient. These are the things you're obligated to, and you will be possibly subject to, drug screening and tests and things like that. So what happens is, you do a drug screen on this patient, and other illegal substances show up in their system, or the drugs that you're prescribing don't show up in their system. So, then it's like, well, that's an automatic violation of that contract. I have this piece of paper that says you violated that. Basically, and I don't think that's the kind of thing where I think you don't really want to play around with it and try to do the patient favors and say, I'm giving you a warning this time. You sometimes have to take a firm, step. And I know you're going to get flack from patients for that kind of thing too, even though they've agreed to it.
So in my state, in Kentucky, we're required to screen minimally for the substance that we're writing, but suggested to occasionally screen for other things as well. Certain substances like Ambien, which we're still required to do that with, will have fast metabolizers for people who only use it intermittently. Mm-hmm. From a risk perspective analysis, are we adequately covering ourselves when we document on there, yes, it was negative, but based on this information from the patient, this fits with taking as prescribed? Or do we still kind of leave ourselves out there because the test result doesn't look good for what's going on?
That's... Yeah, I think documentation is important, from that standpoint. I think about a situation where recently a doctor asked me a question about, apparently he was dealing with a very large patient, and the dosage was more than what would be normal for an adult, but because of his size, and he was saying, that he was trying to justify it on this basis. And I said, well, in that case, I don't know. Because he said something like, well, do I write in the record, like, I know this is probably not indicate, or it's not for the normal patient population, but for this patient. And I said, well, I think there's other ways that you can document that. But again, that might be something where you want to consult with a pain specialist to get some input and maybe some, research on that to document or refer that patient or document appropriately so that you're doing the right thing from that standpoint in terms of some of those clinical issues.
What about the issue of false positives? There's a 10 to 50% false positive rate in most drug screens. Do you recommend doing the split specimen and rechecking it?
Well,
then there's a huge additional cost in who's picking that up.
Right. And have you run into that situation where?
I'm an MRO, so I see a lot of them. So.
Yeah.
There's a new SSRI that tests positive in an initial screen for PCP.
Mm-hmm.
And if you don't have a lot of PCP in your area, that's kind of an odd thing to have come up. And the reflex to confirmation will confirm it negative, but it's expensive.
Yeah. And I think, again, on those kinds of things, I think you have to consider those situations on a case-by-case basis. You have to consider also, your relationship with that patient and what has transpired before, and what, if you have additional concerns. I know there, in that case, who bears the cost of the testing and that kind of thing. That puts you kind of in a difficult position from that standpoint. But I think also you want to do not only what's good for the patient, but also what also in the back of your mind can help protect you as well. From that standpoint, and that's all part of it, I think. Because these, again, when these situations, I've seen too many times where someone, tried to cut a patient a break, whether it's related to opioid prescribing or not following up on a test or getting a test done or a procedure or something like that. And then something happens and the patient comes back and sues the doctor, because they weren't diligent about making them follow up or go play by the rules, along those lines. The pain management agreement, that's, again, something we have an example of that, or that I use, where it's plain language, because, again, you don't know what the patient's health literacy is as far as their understanding. You want to make sure that it's clearly spelled out, in plain English, what is expected, of the patient, and that there's not a lot of complicated jargon or medical terminology from that standpoint, and that it does have specific, parameters for when, if you violate the terms of this contract, then this is what I will do at this case, in this juncture. And applying it consistently, because, you don't want to give a break to some patients. Oh, he's a nice guy, she's a nice person, I'll cut him a break this time. I think you have to try and be consistent along those lines. Here's the other issue sometimes with respect to diversion of actual, medication, prescription pads, sometimes where they're not secure or locked up. And also the other issue about that too is that when writing prescriptions, that when they're not done electronically, is not just to write numbers, but to write out the word as well, the number word as well. So it's harder for a patient to alter those kinds of things, when they're trying to do that. Because, sometimes pharmacies will contact you and say, I have a question about this prescription. It seems out of order, or do you really mean that dosage, or, that kind of thing. So, because again, there is that issue with diversion and fraud. And not only in the, not only with patients, I think sometimes you may, unfortunately, we have come across situations where employees who are working for the medical practice, because they have access to maybe even like the electronic medical record. And I was trying to think where, sometimes they could go in and maybe send out a prescription for a medication, maybe find an old inactive patient, who wouldn't draw any attention, or, there may be ways to game the system in the electronic medical record to get prescription meds. Employees may try to do this kind of thing. I don't know all the ins and outs of it, because I don't have the criminal mind per se, but it's real interesting, and people will be very creative when they want to get what they want to get, from that standpoint. We already actually talked about this a little bit too, in terms of proper termination, discontinuing care, because you want to enforce your policies and procedures with respect to this area, but then failing that, and if the situation is not salvageable, then you want to discontinue care appropriately, and do it formally too, from the standpoint of a, I'm sure many of you have a formal termination letter. And you don't necessarily even have to include the reason for the termination in that letter, because sometimes you'll get arguments from the patient back. So you just want to make it clean and streamlined that, as of such and such date, I'm no longer your provider. But you may recognize for this patient that they do need to seek medical care from someone, and obviously, you want them to do that. But your relationship is such that once you're sending that termination letter, you basically close the door, and you don't want to keep on opening it from that standpoint. Obviously documenting these kinds of things, very important in terms of the issues that you run into, documenting it objectively, not saying things in the record like the patient's crazy and characterizing them with certain, negative terminology, but very objectively documenting their actions and behaviors and the things that they say to you. And, obviously contacting your medical liability insurer, because I think all these situations are kind of on a case-by-case basis.
Brad, why don't we stop there?
Yeah.
We've had a lot of questions during the talk. If there's another question or two that we can take at the microphone, let's do that. And then I want to stay on time for your next presentation.
Okay.
And I think we just have some case studies here. And let's give him a hand for this presentation. This is really great.
Well, this actually was the happy one, though, I think.
Oh, okay.
Because this was a 25-year-old female who had a physical, she was referred to a neurosurgeon. Whoops, what did I do? I just turned it off.
Randy got you.
There we go. Okay. The primary care physician did refer the patient to the neurosurgeon, and basically Patient requested Vicodin. The primary care physician had a pain contract in place, referred the patient appropriately to the neurosurgeon. 3 weeks after, the patient claimed the pills were lost and wanted a refill. And in this case, the primary care physician got a cures report or the prescription monitoring program, and found out that there was, hydrocodone from other physicians, counseled the patient, terminated care because she had an out in that case, recommended addiction care and counseling for the patient. The patient did die because apparently, I guess they were still obtaining medications from those other providers. And there was a family suit where multiple physicians were involved, and of course there was a standard of care breach. The addiction caused death, but the primary care physician was dismissed because of what she had done in regards to dealing with that patient. So that's kind of the happy story, and basically the bottom line is that this is just the thought to leave you with, that this is coming from administrator for the DEA, and says that basically 99.9% of practitioners are doing exactly what they're trained to do. They are healers, and they are protecting their patients. They're not drug traffickers or criminals or anything like that. You guys are healers. You're trying to help patients, but this is a thing that a side issue that you have to deal with. So there we go.
Yeah, and let's give him a hand again for the presentation.